Hello, everyone. I'm Karim Al-Azizi, interventional cardiologist and director of structural heart at Baylor Scott White, the Heart Hospital, Plano. I'm pleased to share with you this important case today, ICE and TE guidance in transcatheter edge-to-edge repair of the tricuspid valve using the TriClip device. The objective of this case is to understand the hybrid algorithm of using intracardiac echo and transesophageal echocardiography in streamlining the case and streamlining the procedure for tricuspid TEER. Let's go over the case. This is an 80-year-old lady with severe non-rheumatic tricuspid valve insufficiency. She's quite symptomatic, class 2 to 3 NYHA. She has a dual chamber pacemaker. She has heart failure with preserved ejection fraction. She has also atrial fibrillation on warfarin. Based on our heart team assessment, her STS scores were quite elevated for replacement and repair. She's 2 out of 4 frail for her grip and her albumin rated at 3.3. Her quality of life scores were quite depressed at 42. She's quite symptomatic with shortness of breath, lower extremity edema, and abdominal distension despite medical therapy. This is her medical therapy, includes several diuretics, including torsemide, Jardiance, beta blockers, and antihypertensives, and despite that, continues to be symptomatic. As part of the workup, the patient underwent a right heart catheterization, which showed elevated right-sided pressures, mildly elevated left-sided pressures, but predominantly on the right side with a normal pulmonary vascular resistance. These are the baseline imaging of her echocardiogram. This is the transthoracic echocardiography, highlighting severe tricuspid valve regurgitation with a pacemaker lead clearly visualized and a wide PISA that originates somewhat deeper within the ventricle, suggesting a potential lead involvement, but a reasonable RV function, may be mildly reduced, and not severely dilated RV cavity. The patient then was referred for a detailed and comprehensive transesophageal echocardiography performed by our advanced imaging team. And as you can appreciate here on the left panel, this is transgastric views of the tricuspid valve highlighting the septal leaflet, anterior leaflet, as well as the pacemaker lead somewhat involved in pinning that septal leaflet open, causing the severe regurgitation. When we take a look on the panel on the right, you can see a 3D echocardiography highlighting the tricuspid valve, but also the degree of regurgitation originating close to the septal leaflet and likely in relation to the pacemaker lead in place. These are mid-esophageal views highlighting the severity of the tricuspid valve as well. Additional views here highlight the fact that the patient does have biatrial enlargement, likely secondary to the fact that she has longstanding atrial fibrillation, and again, redemonstrates the severity of tricuspid valve regurgitation. And these images are key in understanding and planning procedures like tricuspid TEER in order to go in with a strategy and likely success. When we look at the images on the right, you can appreciate a severely dilated IVC highlighting an elevated right atrial pressure in line with severe tricuspid valve regurgitation. Procedural planning, the plan is to utilize right common femoral vein access for the TriClip device, left common femoral vein access with a 10 French sheath for the Philips Verisight ICE catheter, which will be used to guide the procedure. The imaging guidance led by our advanced imaging team as well as us is basically a hybrid dance between transesophageal echocardiography that is used to guide the device to the tricuspid valve, but ultimately will stay transgastric in order to give us clip arm orientation, and ICE guidance for leaflet capture and optimization and making sure that there are no significant shadowing and appreciate the amount of tissue that will be in the device. Our plan is to proceed with 2 devices with the MitraClip XTW, one anterior to the lead and one posterior to the pacing lead to reduce the degree of regurgitation. Let's go over the device itself. This is the TriClip G4 delivery system. It is composed of multiple parts. The CGA, which is the controlled gripper actuation area here highlights that actually we can use this part for independent leaflet capture and optimization. This is the delivery system that sits on top of basically this handle or base. And this is introduced so that you can advance the device into the ventricle and underneath the tricuspid leaflet. This is the area where you can actually bring in the device from the atrium down to the ventricle using the flex and extend knobs on the delivery catheter to steer down. What's important and what's different about the TriClip device as compared to the regular mitral clip device is the septal and lateral movement knob, which basically allows the device to go more septal or lateral as compared to the mitral clip device that doesn't have that knob essentially. And then finally, we have the steerable guide catheter at this end, which is basically meant to have a plus and a minus knob to straighten and bend to add height above the valve and vice versa. These are the device types that are provided in general. Typically, what we use is the XT and XTW devices. The XTW device width is 6 millimeters with a length of the clip arms of about 12 millimeters, and the whole device expands to about 22 millimeters at 120 degrees. This is typically what is used and is essentially considered the workhorse for a lot of these transcatheter tricuspid edge-to-edge repair using the TriClip system. In terms of imaging and specifically the ICE catheter, this is the Philips VeriSight Pro catheter. It is a 9 French outer diameter that will utilize a 10 French sheath with a working length of 90 centimeters. It does have a catheter tip that is quite atraumatic and has 2 steering wheels, basically that will allow the operator to steer in an anterior, posterior, or left and right with a clutch in order to maintain grip and maintain those deflections. The differences between an ICE catheter and a TE catheter are highlighted in the slide. The ability to image essentially in a rectangular arrangement is different from a square arrangement. And so at a 90-degree angle on an ICE catheter, the images may be somewhat limited. And so a lot of times we will be utilizing 45-degree angles in order to utilize the diagonal imaging elements on the ICE catheter as compared to TEE. Following this successful case, she's an 80-year-old who used to be very symptomatic with class 2 to 3 heart failure symptoms. Despite medical therapy, was referred for transcatheter tricuspid edge-to-edge repair after assessment by our multidisciplinary heart team. 1 month post-treatment with 2 TriClip XTW devices, she's down to mild tricuspid valve regurgitation. Her KCCQ scores improved significantly from 42 to 78. And symptom-wise, her shortness of breath has improved as well. Her edema has decreased significantly and remains on diuretic therapy. These are the images of the transthoracic echo at 30 days, highlighting the significant reduction in tricuspid valve regurgitation with preserved RV function, and additional views as well on this segment highlighting the residual mild regurgitation, which is likely related to the placement or the position of the pacemaker lead, but otherwise significant reduction on echo as well as with her symptoms. With that, thank you all for your attention.